Thank you, and I appreciate everybody's understanding for the technical issues. So I'm Joshua Hyman. I am a pediatric orthopedic surgeon. I am the clinical director of the Weinberg Family Cerebral Palsy Center and the St. Giles Professor of Orthopedic Surgery at Columbia. I've been working at Columbia since 2000, and I have the great privilege of being able to take care of children with neuromotor disabilities. I am very much looking forward to tonight's panel and hopefully answering whatever questions people in the audience have.
Hi, my name is Haekyung Kim. I'm pediatric rehabilitation doctor. We call the pediatric physiatrist. I have been at Columbia last 10 years with our outstanding colleague like Dr. Hyman and Dr. Selber. And I am currently professor of pediatrics and rehabilitation medicine, as well as orthopedic surgery. And I'm also vice chair for the rehabilitation department and chief of the pediatric rehabilitation medicine at Columbia and Cornell and Blaisdell Children's Hospital. I have been, I think, devoting my professional life for people with cerebral palsy entire my career. So this is my dream, and I love to talk about what we can do it with you guys. So very nice to meet you guys.
Thank you. And Dr. Selber, yes, you can go ahead, Dr. Hyman.
Yeah, I was just going to say, Dr. Selber is in the operating room. He's finishing up. He's just putting on a cast, and he will be joining us shortly. But Dr. Selber comes to us first after spending about 10 years in Brazil, and then another 10 years in Australia. And he joined us about 2.5 years ago. Mm-hmm. And his entire practice is devoted to the care of people with neuromotor disabilities. He takes care of children as well as adults and comes to us, as you can imagine, with not only great experience, but tremendous enthusiasm. And I think many of you have had the good fortune of meeting him. If not, you will certainly recognize his expertise and enthusiasm this evening. So with that, I'm going to turn this back to Christina for a moment. Christina, just one housekeeping issue. You texted me that you're not able to see the Q&A if you're sharing your screen. Is that right?
Yes. So if you could go ahead and just, normally we use the Q&A function, but if you all wouldn't mind using the chat for the first part of the webinar, and then once I stop sharing my screen, I'll be able to see the Q&A again. So if it's urgent or anything you need answered immediately, go ahead and put it in the chat. If not, you can put it in the Q&A later during the webinar, the Q&A section. So one other thing is, like I mentioned, this will be recorded and we'll be able to save any questions we don't get to, and we can follow up with you after. So go ahead and ask questions anytime during the presentation, and we can go ahead and get started.
All right, so the general format is going to be, I'll present a couple of scenarios, I will present a few questions, and Doctors Kim and Selber will answer them. I'll chime in if, when necessary. But then we'll have time at the end, 20 to 30 minutes, to go over questions from all of you. And I think we could probably twist Dr. Selber and Dr. Kim's arm if we need to. We could even extend this perhaps for a couple of minutes if there is additional questions that are asked. So with that said, again, welcome to all of you. Thanks so much for taking time out from your evening in the middle of the week. So we'll start with a scenario that I suspect many of you are very familiar with. And that is, my pediatrician just told me that my child has cerebral palsy. So the first question, of course, that everybody has is, what is cerebral palsy? So let me ask Dr. Kim if she could please tell us in her words what cerebral palsy is.
So it's easy and difficult to answer. I usually do, right? This is not like a definite diagnosis. We borrow the umbrella, we call the umbrella term. So usually more like how they look, how they move, So for example, someone who walks weird, that we may think about, oh, maybe cerebral palsy. But anyway, so if a child has a known brain injury, we don't like the terminology, but the injury means like infection, trauma, anything happened to the brain, or stroke during pregnancy or around the delivery or after they were born, but before their brain become mature, which means about 2.5 to 3 years old. If something happened to the brain, which brings movement postural problems, those patients, we call that cerebral palsy, which means the brain injury happened. That means that they're not going to progress, but they're always in the hospital. They always have something else. So looks like their lesion is not progressive, but the complication from the brain lesion is progressing. So that's the one thing. But so they have brain injuries, but their intelligence not all the time involved. So some children are normal, some children is a little involved, some children is more involved. Nowadays, genetics has been developed. So about 15% patient with the diagnosis of a CP, their picture of the brain is not abnormal, it's normal. So then you're gonna tell me that, Dr. Kim, how come my child has a cerebral palsy? You know, we got the MRI that was negative, right? So we send them to genetics, and then they will find out something wrong with their genes, but some doesn't. So still it's not clear. So that's the way I start to explain, and then we investigate more and more.
Yeah, no, I think that's very good. The point is that it is fairly unclear exactly what it is, but the most important point, I think, for parents to recognize is that it is a non-progressive neurological condition. By non-progressive, what we mean is that the problem with the brain does not worsen. There are a number of childhood onset neuromuscular conditions that get worse as the child ages. Cerebral palsy is not like that. In fact, the neurologists like to call it a static encephalopathy. That is static, it's unchanging, and encephalopathy means a problem within the brain. And in fact, most neurologists, frankly, are not terribly interested in cerebral palsy because of its static nature. However, with that said, functionally, it is not static. And that's where rehabilitation doctors and orthopedic surgeons, physical therapists, they can provide some assistance. As the child grows, their function can change. And without treatment, unfortunately, the function will frequently deteriorate, even though the fundamental injury, the neurological injury, is in fact static. And that's the other issue is that Dr. Kim mentioned we don't like to use the word injury. She and I are both too old. We can't help it. We use the word injury. Right. Because that was our fundamental understanding. And as we're learning more, as Dr. Kim alluded to, we're learning more about the genetics of CP and that there are very likely genes involved, either in directly causing the condition or certainly making some children more susceptible to the condition. And in some, it may not be an actual injury to the brain, but we're learning. We are learning. So with that said, you have some, I hope, understanding now as to what cerebral palsy is and what it isn't. But then the question is, what do we do now? So let me again put this scenario out. Your child has just been diagnosed with cerebral palsy, and you now have the good fortune of being in Dr. Kim's office. So, Dr. Kim, what do you say to these patients?
Welcome to your paradise. First, so if I were parents, I would be very confused by the diagnosis. What does that mean by cerebral palsy? So I don't start with the diagnosis first. I just let parents talk to me. And then I think the most important one is their question is, what's going to happen to my child, right? So I explain about the definition of cerebral palsy and I assess the child. And then I go with a whole review of systems because it's brain problems, which involves, it can involve everywhere. So I try to make sure that anything we miss. So I try to kind of be their primary doctor for that condition. So I try to find out which subspecialist they need, number one. And for example, we may need to send them to neuro-ophthalmology, neurologists, or GI doctors. So we try to be center for those care as much as we can. And then after then, I many times if they're young parents especially, or if they are first child, and then I ask them, your child could be could have a diagnosis for cerebral palsy, but would you like to have the diagnosis for your child? I ask the questions too, because still parents are confused and they don't know what to do. So still we are figuring out, but my role is to start the therapy first. After I identify the problems / difficulties, and I write down all the subspecialists, refer. In a way, first visit, I don't refer my patient to everywhere because the parents is going to be so difficult to follow this all the direction, but one or two very necessary subspecialists. Then I initiate the therapy. Or if they are already in early intervention program, we try to work with them. And then other stuff is, do they need any other equipment or brace? Just to, we try to work on their needs first. And then we become partner with the parents, and then we try to do one by one.
Yeah, I think you've raised some really important points. The first, of course, is recognition that when the parent, the mother, the father, frequently both come in with the child with this new concern, they are overwhelmed for all sorts of obvious reasons. And we as clinicians do not want to behave too clinically and just throw out a lot of medical information and a lot of prescriptions and send them on their way. We do need to listen and really get a sense as to their understanding. That's the first thing I try to do, is gauge their level of understanding as to what's going on, and try and fill in those gaps that I think are really critical. I also agree that sending them on to a whole bunch of other subspecialty referrals at that initial visit tends not to be very important. If it's anything critical, if they're having real feeding issues, by all means, get them off to gastroenterology. But first and foremost, we, both you and I, Dr. Kim, as functional clinicians, we want to try and improve their function. I agree, starting out with therapies, physical therapy, occupational therapy, is very helpful, or getting them involved with early intervention and so on. So let's say now that they come back and it's their second visit, and thankfully the child is reasonably healthy, but they're not feeding terribly well. They're breathing okay, that's not so much of an issue, but they're not doing a lot. They're just sort of lying in the crib. They don't seem to have a lot of strength. What now? What else can you recommend for this child?
It depends on their age. Age is very important for me because that let me think about their future function. So if the child is really like younger than 2 years old, I really have to rely on therapists to move forward, which means try to remove some reflexes, go on to the right motor milestone, especially. But if they're like 1.5 to 2 years old, if this child is still not walking, then we have to work with orthopedic surgery together. Hip surveillance is very important for me to address if they have a muscle always children, most of the children with cerebral palsy has a mixture of weakness and stiffness. Some very few patient has only weakness, but most of them very mixed tone they have. So I really have to make sure that I work very closely with the therapist that what area they have to improve. That is very important for me. And then orthopedic surgeon, my partner, is extremely important because we have to work side by side to prevent further problem/complication from being weak and tight. So that's what my next step is going to be.
So, that's a really good point. Elaborate on this for me a little bit, because frequently when the parents bring their babies in, the babies are floppy. They're not tight. And the children are often, people with cerebral palsy are often said to have spasticity. They have spastic cerebral palsy. And spasticity means this tightness, this rigidity. Can you just elaborate a little bit on the evolution of tone from babies to childhood, and how they go from floppy to tight, and what these different terms mean?
Right. So thanks for asking that questions. That's still, we don't know how that happened, but my own theory. So let's say when the baby had something happen to the brain going into kind of a shock, so that they don't do anything. Let's put that way. We don't know exactly what's going on yet, but that's the way I understand. So the most of a baby who had a problem in the brain, their muscle usually become loose, initially lower than normal muscle tone. So Dr. Hyman is using floppy. Sometimes you feel really your baby is a little floppy. But as time goes, most of patients start to show a little bit of stiffness in their arms and leg. If they are quite involved case, then usually that happens between 6 months to 12 months, a little later than that. That's why we pay attention a lot around, because 12 months means they are in growth spurt. They are growing triple size compared to when they were born. So their size is completely different. So that gives a lot of difficulty for this baby. So they become stiff. Then as time goes, we just to talk to you guys that, oh, this is non-progressive problems, right? Then, but you see some problems, your son or daughter looks even worse than before or better than before. So while they're growing, their brain's still developing within about 2.5 years after the birth. Mostly they get better actually. But in terms of muscle stiffness, they get worse. Because I was saying that their bone has no stiffness, but muscle has a stiffness. So whenever bone tries to grow fast, stiff muscle cannot catch up the bone growth. So you start to see more stiffness in the groin area. You have difficulty with changing the diaper, ankle gets stiffer. All the stuff are coming more after 1 year old. And then when they become 3 years old, another growth spurt is coming, and then you start to see more stiffness, more deformities. That's the way the tone evolution goes, but not tone is really changing. Only real changes between 0, at birth to 1 to 1.5 years old. After then, actually, they have a same type of stiffness, but because of growth, looks like their spasticity or stiffness is getting worse.
Yeah, that's exactly right. The way I try and describe it to the parents is that imagine a suit on a growing mannequin. And as that mannequin is growing, the suit does not grow, and it gets tighter, and it becomes more difficult for the arms and the legs to move. And that's the bones and the muscle. The bones in a child with cerebral palsy are growing normally. It's the muscles that are not, and that's because of the primary signaling from the brain don't stimulate the muscles the way they're supposed to, and then the muscles don't respond and grow appropriately, and the child becomes stiffer. Over time, they eventually equilibrate. They can loosen up a little bit, either with therapy or time, until the next growth spurt. So we've sort of gotten into this discussion now of function. Let's proceed and talk a little bit more about what we can do to help. If you would, Christina, give us the next set of slides, please. Thanks. So now we're getting a little bit older, and we're going to be talking about, Dr. Selber is here. Perfect. So Dr. Selber is back from the operating room.
Sorry for the looks. I apologize.
No,
It doesn't get any better in normal days anyway.
You look terrific. You look very professional.
Okay.
So, Paolo, we just finished talking about newborns, infants, toddlers with cerebral palsy, how to go about the evaluative process, who should be the people initially involved in the care evaluation. Now we're talking about older people, teenagers, and now we're also discussing adults. And I've explained to the audience that you take care of both babies as well as adults, and of course, everybody in between. So let us say the people in the panel, one of them is an adult with cerebral palsy. What specialists should they be seeing, Dr. Selber?
Well, I think they should always see a rehabilitation physician, because rehabilitation physicians or physiatrists, I think they have a very good and global sense of what CP does to people. We know that one of the most involved systems in the body, thanks to cerebral palsy, is the musculoskeletal system. So then very often they will have orthopedic complaints. You know, the walker, the people who are able to walk, sometimes they their gait, the way they walk may deteriorate over time. And we orthopedic surgeons at times can help. And the people who are wheelchair users, sometimes they have problems with knees and hips and feet. And we could try and help as well. Very often they have severe contractures that hurt. And so I think between the physiatrist and the orthopedic surgeon, and of course, if the patient has anxiety and depression, and if the patient has seizures or epilepsy, then they need to see those specialists as well.
So that's a really good point. I'm glad you brought up anxiety and depression, because that's something that we at the Weinberg Center have spent a significant amount of time actually researching and trying to uncover. Dr. Kim, can you talk a little bit about what we've found regarding anxiety and depression in people with cerebral palsy?
Right, this is extremely important point for us to address. Thanks for bringing that up, Dr. Selber. We did a retrospective study at Weinberg CP Center a couple of years ago. We found that the most common mental health problem is anxiety. About I think 80% patient had it, and depression goes to next, which is about 50%. Whoever came to the Columbia system, we did review those cases. So, but that's a study. And then my problem, I think all our problem is many doctors don't know people with cerebral palsy. They know when they were young, kind of, but when they grow up, even we didn't know until we had a center, right? We didn't pay attention that much because we are pediatrician. So we have to push our patient to the adult doctors. So we had the trouble, but ever since Dr. David Roy opened the Weinberg CP Center, I really pay attention to this patient population. Most of them all have, I think really more than half of my patients were on antidepressant, no matter what, right? But we don't know how they started, who is managing their one, what's the problem. But as I get to know more them, they may not have depression even, because we don't understand their problem. Of course, they have anxiety, they have depression, but if we understand them better, we can really minimize their mental health problem. Because, you know, I analyzed 250 patients in our center, and then the most common reason to visit our center was pain. But we even didn't address the pain for a while, right? So mental health wise, absolutely, we have to ask the questions, we have to address, we have to help them out to treat. But before that, we have to really have a thorough review of our patients,
So,
which can be cause for the anxiety.
so that's absolutely right. Christine, if you would go to the next set of slides. This is fine. We can leave it here for now. But you raised the question of you raised the issue of pain, and one of the questions that just came in actually is just about that issue. I think it's important to recognize that pain is very unusual in young children. Babies typically don't experience pain because of their cerebral palsy. Toddlers typically don't experience pain because of their cerebral palsy, and even young children don't. It's not until they get to be older, into their young teen years, and of course older into adolescence and unfortunately adults. I'll talk to both of you, but Dr. Selber, if you could start and explain a little bit to try and to help us understand, why don't young children have much pain? But then as individuals get older, they do seem to experience pain, and it can become a very significant issue. And then if the two of you could also discuss what can be done to alleviate it.
So I think adults have pain because we always have to talk in CP about the two populations, the CP patients that are able to walk and the CP patients that are unable to walk and they're wheelchair users. The people who are able to walk, often they have pain because they either have deformities in the lower limbs that were not corrected, or they were ill corrected. And the other thing that happens is that as we get older, and this applies to all of us, we tend to get stiffer. And in CP, they start from they're stiff by definition. So when the muscles become stiffer as we age, and the joints primarily starts getting stuck in one or the other position, that's when the pain starts to hurt. Pain starts to occur. It's like when you go, and most of you who have CP will agree with me, it's like if you go to the cinema and we were to watch a movie for 10 hours and we were never to extend our knees. Eventually the knees start to hurt or the hips start to hurt. The other frequent cause of pain is the spine. Over time and as we age, the same as in typically developing people, we start having disc problems and disc prolapse and arthrosis of the spine and other joints, and those things tend to hurt as well. And lastly, when patients have a lot of stiffness, a lot of dystonia, and a lot of spasticity, this is like running a marathon all day long, every day. So eventually the muscles go in fatigue, they cramp, and this needs to be addressed. It's not until they're relaxed a little bit that the pain goes away. One thing that I find interesting, and I think this is my best advice to you all. I have a lot of patients, and in Australia it was the same, that they were being treated for pain. And then when they come to me, I say, okay, you've been treating for pain, but what is hurting and what is causing pain? And in a lot of occasions, the patients don't know, and the people who are treating them were never able to diagnose. So I think the first thing that I do when I see someone with pain is to try and understand the cause. What's making this person hurt? Because it's not only about treating pain, in my opinion, it's about treating the cause. If we can find a cause that it's treatable, and it doesn't necessarily needs to be orthopedic surgery, it could be medication, it could be Botox, it could be other things, physical therapy, etc. But we need to address, when we're seeing patients with pain, we need to understand or try and do our best, I think, to understand what is causing the pain. And then we take it from there. And then we say, okay, this could be treated this way or that way or the other way.
Agreed. Dr. Kim, you have a tremendous amount of experience in both analyzing pain in people with cerebral palsy and also treating it. Can you talk a little bit about what you believe the pain generators to be, and what do you have at your disposal for alleviating this pain?
So number one, I just want to correct what Dr. Hyman says. The children do have a pain. They have a pain. That's our mistake, right? So younger children, like 1 to 3 years old, the most common etiology for pain for those age is GI problems. We know that. Reflux, constipation, gas retention. So that even the study showed that one. And then as a teenager, so if we do literature review, the pediatric population, about 50 to 65% of children with cerebral palsy has pain. And then adults, 87% to 100% patient has pain, but we don't ask, so they have no chance to talk about it. The most common cause for pain is actually hypertonia, stiffness. We analyze that one. And then the way I approach pain is try to find out the pain source, but meanwhile, since we know hypertonia can cause pain, I start to treat the hypotonia while I'm looking for the pain source. So if this is from the spasticity, fatigue, overuse, then most patients relieved from botulinum toxin injections or antispastic drug. But if that doesn't really improve pain, meanwhile, I get the X-ray, take a look at their biomechanics, all the things, and GI. So top to bottom, I rule out every problems. And that's the way we can find out the pain source. But to me, initially I was not treating them. I said, I have to find a pain source, how it's gonna mask if I treat their pain. But I don't give a pain medication, but I try to relax the stiff muscle while I'm looking for the pain source. That works. That doesn't confuse us. But many times we have to remember our patient who has more pain, they are not able to talk. So I know it's important for us to look for the pain source before we treat, but in a way we have to treat and look for the pain source if they cannot talk.
So look, it's a great point. It's my shortcoming as an orthopedic surgeon. I don't consider the GI symptom or GI issues as causing pain.
I understand,
Right.
Joshua.
Reflux is very, very common amongst all children, but young children. But you're absolutely right. It is far more common in those with cerebral palsy. You talked a little bit about some of the treatments that you have to offer. You mentioned Botox. When should you give Botox? When is the appropriate time? What are your indications for utilizing it?
So why you have to ask when? When is I never ask when to me, because if patient needs it, that's the time to start, right? So I live on early intervention, early detection. If I find that my patient needs botulinum toxin injections, I usually start even younger than 1 year old. But I try not to start in younger than 1 year old. So around 1 year old, I start severe cases. I start around 1 year old. But remember, the study with the botulinum toxin has been done for older than or at 2 years old. We have that one, but many clinicians have been using botulinum toxin younger than 5 months old for various reasons.
Can you give us some examples? What do you use it for?
Torticollis, the tilted neck, and strabismus, the squid eyes, and then like my case is salivary gland injections to stop the drooling to prevent aspiration pneumonia. So my youngest patient was 1.5 months old for salivary gland injections.
Is Botox effective for that?
Yes, and then recently actually FDA approved that botulinum toxin use for the salivary glands at between, let's say, I'm trying to remember, 2 16, I think older than 2 to 6 years old even has been approved. Let me double check, but recently approved for
Sure.
adult and teenager and younger children. So that's why age is a little confusing, but at least you're older than 6 is definite. But I'm trying to remember between 2 to 4, 6.
Well, tell me this, what does Botox do? How is it helpful?
So actually, initially I started to think it's the working on the neurotransmitter, which means like nerve has to stimulate the gland to produce the saliva. So we are blocking the nerve just like muscle. But as we use this botulinum toxin to the glands, actually that mechanism is different. Nobody actually clearly know the reason why, because different nerve, botulinum toxin also works for the different nerve. Not only we call the acetylcholine, but also we call the sympathetic nervous system works. So we still don't know clear mechanism, but obviously people will say they're always working for the nerve to the gland.
Fair enough. But aside from putting aside salivary glands, what about for leg muscles and arm muscles? What does it do? Why is it helpful? Why should my child get Botox?
Right. So botulinum toxin is toxin, but when we give medication, this toxin to the muscles is like we call the blocker, neuromuscular junction blocker. So when we have to move our leg and arms, nerve has to give a signal to the muscle to let them move, right? But when I give a botulinum toxin to the patient, I am giving this medication between the nerve and muscle, and the nerve is going to take over the medication and it's going to block the signal to the nerve. So partially, so we cannot really block all the nerves, so patient can still move, but they are much less stiff for a while. So you're going to ask me why you have to repeat the injection. This medication temporarily works for the nerve blocking, and the nerve is going to regenerate. It takes about 3 to 4 months to regenerate. That's why we may need to repeat the injection every 3 to 4 months, but usually most of the practitioners, they try to do 2 to 3 times a year.
Perfect. Thank you. Dr. Selber, we have a few questions about surgery, and there are a couple of questions from the panel as well. Putting aside adults for one moment, just talking about children, when should a child with cerebral palsy be seen by an orthopedic surgeon? What are some of the issues that may arise that an orthopedic surgeon might be able to help with? And if you could, talk about how safety about surgery, what their expectations should be around surgery, what should the child be like afterwards?
Yes, thank you, Joshua. Again, I think seeing an orthopedic surgeon that has experience with CP is important, probably around the age of 2 or 3, depending on the child, of course. If we have a very involved child that is at risk of dislocating hips, the hips coming out because the muscles are pulling in the wrong direction, we would probably like to see this child as early perhaps as 1 or 1.5 or 2 years of age. If we have a patient that is going to be a walker, the same. I think we'd like to see them to start with at 3 years of age or 2 years of age or 4 years of age, depending on the severity of the cerebral palsy. Proposing surgery to children is a big enterprise and a big challenge for the parents to accept as well. And I don't blame them. I like to see patients early on because we know a bit about the natural history of the disease according to the gross motor function classification system. And when I know more or less the natural history of this or that, what I start to do, and let's keep it as a secret, don't tell anyone, but I like to start giving the parents what I call homeopathic doses of information. How does it work? If I see, for instance, a pair of hips that start to move a little bit, and we did Botox and Botox is not working, and we did bracing and bracing is not working, I start saying to the family, look, we have to keep a very, very close eye on these hips, doing what we call hip surveillance with x-rays every 6 months to 12 months. And eventually we'll need to be more aggressive, because if we let these hips dislocate, not only these hips will tend to be painful, but it's going to cause a series of other deformities, spine deformity, pelvic deformity, and so on. So if the child comes to an orthopedic surgeon and the orthopedic surgeon understands this natural history, the surgeon starts preparing the parents. And I can tell you, back in Melbourne in Australia, and I'm still talking about Australia because I just came from there, because we had a very good control of the population. It was often the parents that came to me at a certain point and said, "Dr. Selber, what are you waiting? Aren't you going to do the hips? Look, the hips were here, and now they're 50% out. And what are you waiting?" And I might be waiting for this or that and the other, but it makes it easier for the parents to understand why we need to do surgery and when we need to do surgery. So following with back in Australia, we used to call ourselves, and this is not to show off or anything, but we used to call ourselves high volume CP surgeons, because that's all I do, all I've done in the last 25, 26 years. You need to find someone who has experience, who has expertise, and I'm not the only one around in the United States, but you need to find someone who has expertise. And let me tell you, there's a lot of people out there that give it a go, but they're not truly high volume CP surgeons. And that's when not ideal surgeries are done, and and sometimes the results at short term are really good, but then in the long term, they're not all that good.
That's a very, very good point. Parents should really be seeking out specialists that are working in a center that has a large number of patients with cerebral palsy that have a great deal of experience with cerebral palsy specifically. I agree with that completely.
Yeah.
We have a question about seminal surgery.
Semels.
Yes.
Yeah.
Can you talk a little bit about what that means, what it stands for, and how we think about it as orthopedic surgeons?
Yes. So I'm going to tell you a little bit of the history behind this, and I'll try to be brief. In the 70s and 80s, the doctors then...
First, if you would just tell us, what does it mean?
Yeah, SEMLS or MLS stand for single event multi-level surgery. And we actually have moved from that term. We've moved away from that term. And now we use MLS or multi-level surgery. In the past, people used to do a little bit here, a little bit there. And they realized that the kids spent most of their infancy and childhood in hospitals or in rehab centers or in the casts. With the advent of modern three-dimensional gait analysis is an exam where we study the way these children walk, and we understand better all the problems that are happening. We were able to fix more things at the same time, okay? So 25 years ago, when I started my career, the term that we used was SEMLS, single event multi-level surgery. So we did as much as we could in one operating set, in one go, always based on gait analysis, not based on pure physical examination. But then as time went, we realized that some of those surgeries perhaps could be postponed. And then we even realized that some of those surgeries that we're doing weren't necessary. Like, if a child has a very stiff knee and the knee doesn't bend, we used to do a surgery to try and make the knee bend. And now we understand that if we fix another couple of things, we don't need to do that surgery. So that's why we migrated the term from single event multi-level surgery to just multi-level surgery. And what does it mean? It means that if we're in doubt, we don't do it, okay? We do what we are absolutely positively right that it's going to help the kid. And if there's one or two procedures that we're not quite right or certain about it, we prefer to leave it alone repeat gait analysis 1 or 2 years post the index operation, the first set of operations. And if the problem is still there, then we fix, only 1 or 2 problems.
That's a very good point.
What we call multi-level surgery nowadays.
Yeah, that's a very good point. The idea is that there was a presumption for a period of time that you could take care of all issues of gait with one sitting in the operating room. And it turns out that that really is not possible, and it's not a terribly sophisticated way of thinking about it. And a better way is to, with gait analysis, really hone in on what the specific issues are, address them, and then with time and growth, reassess, another gait analysis, very thorough evaluation, and then be prepared for a little bit more surgery. And we sometimes will use this term, tuning the child up. And figuring out what else can we do to just make them that much better. And then in all likelihood, they should be through their growth, and their situation should be somewhat stable. We have another question here about what can a young adult do about toe walking? I'm not entirely sure what age this child is, but I presume since this individual happens to be a girl, since she is making her own autonomous medical decisions, she's probably an older teenager, young 20s. But now she's up on her toes, presumably according to her parent, because she wasn't doing very much for the last few years. She's gotten stiff. Yeah. So both of you, can you address toe walking in a, let's say, a 20-year-old? What can you do, Dr. Kim? You're on mute, Dr. Kim.
I'm trying to read all the questions. So, so this patient has cerebral palsy, but toe walking?
Presumably.
Okay, 20 years old, very unlikely that happens, right? But if a patient, I will send the gait analysis first to analyze his gait. I think that's very important because it's very unusual for me that 20 years old is still on toes.
Well, I think that what they're saying is that she had been walking more plantigrade and then didn't do very much in the way of therapy and stretching and self-care as she was becoming more autonomous, which is not unusual.
Okay, now I can say that I will assess her more carefully because not only tightness in her ankle joints, but mostly we see actually hamstring tightness causes toe walking in many cases. So we have to assess the patient carefully, but I will still work with the orthopedic colleague together. But if I know what is causing toe walking, just like what I said, is if there's a muscle stiffness is causing this toe walking, but stiffness is simply in hamstring and gastrocs, I will try to do botulinum toxin injection to those stiff muscles. Meanwhile, we are going to arrange the more evaluation with the orthopedic surgeon and gait analysis, but I will try that first and see how they do. But if they have ankle contractures, then another simple one is we can do casting. Casting is very effective. So in terms of like a rehabilitation wise, I will try to treat that way.
Terrific. Paolo, what do you think? What would you as an orthopedic surgeon, how would you address?
Yeah, toe walking is a very delicate matter because the calf muscles are some of the most important muscles that we have to keep us upright. And again, if you get what I call the wrong surgical dose, and I know that I don't say that word very well in English, dose as in D-O-S-E. If you get an over-lengthening of the calf muscle, the next step is going to be worse than toe walking because now your calf muscles are so weak that you go in what we call crouch. And crouch is really hard to fix. So I think one of the things that I've been trying to pass to a lot of people around is that every patient you can't apply the same rule or the same surgery or the same amount of Botox or the same treatment to everyone. Yeah, we need to individualize treatment. As Dr. Hikyang said, if this patient has a mild toe walking, if the calf muscle is not too tight and there's no fixed deformities in the ankle joint, perhaps a little bit of Botox and a little bit of serial casting will take care of the problem. If we have a fixed deformity, if we take an X-ray of the ankle joint and the ankle joint has already been stuck in that position for a little while, Botox is not going to do anything, or serial casting is not going to do anything. Then we need to move on to the next step, which is surgery. But then what surgery? Because we as orthopedic surgeons, we can lengthen the calf at different levels with different intensities or with different dose. Meaning we can make the calf very long and very weak, or we can make the calf just right. How do we make that decision? Well, normally we make that decision by physical examination, by imaging, sometimes by gait analysis, to put it all together and say, okay, how much more range I can give to this patient. And on the other hand, what happens very often, I hope people understand that I'm not saying what I'm about to say just to advertise. It's not what I mean. I care for these patients. If you go to a person who doesn't understand the concept of dose, you're going to get a tendon Achilles lengthening, and sometimes even percutaneous, because they brag as a fantastic surgery. And that's the worst surgery that this person can have, because they lengthen the Achilles tendon without any control, and the calf is totally wasted. And then 3 or 4 years later, the real results of these surgeries don't happen in the next 6 months. It happens 5 years down the track. The person then comes to me and says, now I'm in crouch. And this person also, unfortunately and sadly, does not realize that the crouch that they're in now is because of that surgery that was done 5 or 7 years ago. So toe walking is a serious thing. It's not simple. You can't just simply go there, oh, I'm just going to cut the Achilles tendon and make it longer. Yeah. We need to pay a lot of attention. There's one question there that I see. When should gait analysis be done? Well, firstly, remember, gait analysis is not treatment. Gait analysis is a scan of gait, and it helps us design the plan for treatment. Not only surgery, but sometimes Botox, selective dorsal rhizotomy, and other things. When do we send the patients for the first time to the gait lab? When we're starting to consider a major intervention, either selective dorsal rhizotomy, or surgery, or orthopedic surgery. Children that are very young and immature, they just don't tolerate to do the exam, because the exam takes about 2 or 3 hours sometimes. So children have to have certain maturity before they can go to the gait lab. And remember, the gait lab doesn't treat anyone. I don't want to be too pedantic, but the gait lab doesn't treat anyone. The gait lab helps us understand what's happening with that person's gait, of that person's way of walking, so that based on that very detailed and extensive data, we say, okay, I could do this, we could do that, or we could do the other kind of treatment.
Terrific. Paolo, there's a question about people with cerebral palsy being at risk for damaging their hips. Does that hip damage occur only while they're growing, in other words, as children, or can adults also wind up with hip problems that they might not have had when they were younger?
Yeah, that's a very, very good question, and you're right. I've seen adults all along in my career for many reasons, and people with CP are just people, just like anybody else. My simple way to, and I hope nobody takes that as an offense, but I say to my kids, all you have is a pair of stubborn legs. Everything else about you is typical. You're just a cheeky kid with a very good sense of humor and so on. So anything that can happen to the hip to anybody can happen to the CP hip. The problem in CP is that sometimes, because they use more forces and they put more strain and stresses over their joints as they walk. Sometimes the joints, not only the hips, but at times the knees and the ankle joints can wear off earlier on. So we need to watch them and see what's going on. For instance, there's a common problem in hips with many people, including myself. I had both of my hips operated, called cam impingement, and that is when the femoral neck hits the socket in the pelvis and sometimes damages the socket. This can happen to anyone. And so whenever people come to me and say, my hip is hurting, I start looking for the reasons for those hips. Why are they hurting? And sometimes we can't find. I must be honest. We search everywhere and we simply can't find the reason. But we try hard. And if there's a reason, we try to treat it, and we'll find what's the best treatment for that kind of hip pathology or knee pathology or foot and ankle pathology.
Terrific. Thank you. Dr. Kim, I see you're working on a reply to a question about baclofen pumps. I'm sure there are a number of people in the audience who also have questions about baclofen as a medication and pumps as a modality for delivering it. Can you talk a little bit about when baclofen is used in general and how it is used with a pump, what that does for the individual?
So the intrathecal baclofen pump is working diffusely. So if someone who has a very severe spasticity or dystonia, which cannot be controlled by local injection with the botulinum toxin or alcohol blocks, or someone who has very severe pain from the hypertonia, those can be candidates. Only what I'm trying to say is oral baclofen by mouth. The medication I tried not to give to the children who has quadriplegia, not the hemiplegia, not diplegia. But the reason why I'm saying this one, because it does cause some gastritis and reflux. So actually the tone can get worse if we don't monitor them carefully. Not everybody, but quite a number of patients can develop the problem. But someone who walk around, but with the spasticity, they don't have that much problems, but they may become tired. So I try to not to give the anti-spastic drug, muscle relaxant by mouth as much as I can. But if I need it, I give it temporarily when they are in pain or during growth spurt. If they need more treatment, I add, but I try to discontinue those medications because it works systematically. But intrathecal baclofen pump, only if you have to give a 100 milligram of baclofen, oral baclofen, less than 1 milligram can be more effective when we give through the pump. So very little amount of medication is going to bring great outcome to control the spasticity. Problem is you have to refill. If there's a mechanical problem, pump malfunction, which happens less than 2%, but catheter disconnection, infection, so there's mechanical problems. But this is an important tool for treating the severe spastic people as well as dystonia, someone who has dystonia.
Yeah, no, baclofen can be very helpful when used in the right patient.
Yeah, and especially I start to recommend the intrathecal baclofen pump more to adult with the cerebral palsy, because as you mentioned, adult with the cerebral palsy has 87% to 100% of pain. Yeah. Some of them have very severe pain. No matter what, we have no control over the pain. So then we do trial of intrathecal baclofen, and they relieved their pain so well, and then they're asking for it. So yes, mostly pain control are used for intrathecal baclofen pump even.
It seems that relieving spasticity in adults is really critical to reducing their pain. And you can do it in a host of ways. You can do it surgically by lengthening the muscles, relaxing the joints a little bit. You can do it with Botox, weakening the muscles, relaxing them and relaxing the joints. You can do it, as you just mentioned, with baclofen. We also have a couple of questions about non-surgical ways, non-medication ways. And I think what they're honing in on is physical therapy. And I'll just give my experience and what I'd like to tell the kids as they're getting older, when they're becoming teenagers and certainly into young adulthood, that just like any other teenager, physical activity is really important. So as people get older, they don't go to therapy. They tend not to go to physical therapy any longer. But that's not to say that they don't need physical activity. And there's plenty of really good evidence that the stronger you are, the better function you will have, and the decreased and the less pain that you will have. So I try and encourage my young adolescents and older adolescents to get to the gym, just like all of their peers. Start lifting weights, get on the treadmill, get on a bicycle, do more. The more they do, the more functional they will be, and frequently the less pain they will have. It's a fine balance between how much pain they have and how much they can do, but they have to, just like everybody else, they do have to work through it a little bit to achieve that goal. So I want to respect everybody's time. It's now a few minutes after 8 o'clock. I think we've gotten through most of the questions, and we've tried to lump a few of them together where there's a theme. There is one theme we haven't addressed yet, and I want to give both Dr. Kim and Dr. Selber a chance. Just quick 30 seconds for each of you, and that's about long-term effects of Botox. We have about 4 questions about that. What are the long-term effects of multiple Botox treatments, and are there any issues or concerns with it? We'll start with Dr. Kim, please.
Absolutely. If you do surgery in same place 5 times, there's a scar left, just like that. If we repeat the injection in same place, absolutely there will be scar, which means that we call it fibrosis. But since we know that, we try to inject in different sites and different intervals, and then using the physical medicine too. So I always give this example. I have a patient who comes to me over more than 10 to 12 years. They are getting botulinum toxin injection regularly, twice a year. I use ultrasound to do injections, so I know the quality of muscle. Actually, I don't see that much atrophy, actually. So if we use botulinum toxin wisely, we can prevent unnecessary complications such as muscle atrophy, severe shortening of the muscle. But I can confess that if I give a high dose to one place continuously, absolutely there's a permanent damage in the muscles. And then botulinum toxin works until they develop the antibody, which means it works for some patients forever. I see, like, even one of my patients comes 15 years, still works. But the reason why you don't feel that botulinum toxin doesn't work after 2 to 3 times repeat injections, because dose of the Botox for this patient is same, but their body is growing. That's why you don't see the difference.
Yeah, I think that's a really good point that you made before about how you administer it, and that you do it with either image guidance with ultrasound or EMG guidance with electrical stimulation, so that you know that you're administering it in the proper place. If the Botox does not go in the right place, it's not going to be effective. And I really applaud you on particularly being so fastidious in how you do it, and that's why I think you have such good results. I think we're going to stop here.
Oh, sorry, Dr. Paulo.
You know, it's 6 after. I'm so happy that the audience has been as engaged, and they've been asking really great questions. I like to see themes in questions. It means that people do have the similar concerns. I think that the 2 of you have done an outstanding job in responding to the questions as best you can. We have this recorded, and we will go back through the questions, and I'll ask Drs. Kim and Dr. Selber, if needed, they can respond. I see that there is a question about SDR. We did not talk about selective dorsal rhizotomy today. We don't have a neurosurgeon on the panel. We do have a neurosurgeon who can answer it. And I would suspect that maybe at the next panel webinar that we have, we'll try and get our neurosurgeon to participate, and he'll be able to speak to that issue and those important questions. So with that, I want to thank everybody for their time this evening. I wish you have a good rest of your evening, and I look forward to seeing all of you and others at the next upcoming webinar. And I want to thank Christina Coleman also very much for helping to organize it, working out the nuts and bolts, and helping Dr. Selber and Kim and myself to coordinate and get this off the ground. Thank you, everybody. Have a wonderful evening.
Thank you for attending.
Thank you very much.